Welcome everyone. This is Dr. Jaitly, your nuclear cardiologist on MuniMeterHealth, your favorite video site for learning cardiology and of course human heart awareness. We are dedicated to medical education and of course patient education because we know the two together will lead to better clinical outcomes. No question about that, and that's my deepest belief. And of course now in the form of a beautiful video channel that we have presented to you through MuniMeterHealth. My global initiative is now catching on with masses and masses all over the globe. So thank you again for associating on MuniMeterHealth. Without any further ado, I'd like to delve into the subject matter today. A very short video as to what defines an ischemia, what defines an infarct when you're doing a nuclear scan. Now, this is mainly for our medical students and residents and fellows, especially training for cardiology, etc. And of course, a good brush up for the colleagues who are already in practice like me, because certain things, of course, have changed in medicine and so also in cardiology, but there are certain things that haven't, and these are the landmark cornerstones of cardiology. But again, for general masses, it's very imperative that nuclear cardiology test, if a nuclear scan any patient has been recommended, understand it's absolutely safe, except that unless you are pregnant, then of course the doctor will not order it and you should not go for it. Okay, so without any further ado, let's delve into the subject matter today. Let's understand what is ischemia versus infarct in a nuclear scan and how is it detected. Now here is a schematic for the coronaries that I normally draw. So this being the left circ, because you know that right from the beginning of the aorta, the aortic cusps, these are coronary cusps, if you will, and there's one non-coronary cusp where nothing arises, obviously, but the coronary, there are two coronary cusps, right and the left. So the right will become the right coronary artery. From the cusp there will be a coronary ostia, and then the artery originates and descends on the right side of the border of the heart. The left circ will be somewhere here, that will go around the left heart border, and the left anterior descending comes down here as it's been shown here. So these are your three major arteries which are supplying the heart. The heart supplies the body, and again for the medical students, just so that you know that there are two sets of coronaries. The left will divide very early on and the right will just continue as is, and of course supplies the right versus the left respectively. Okay, so having said that, now you understood, basically the nuclear scan is defined where you actually perform radioisotope stress test, where the person walks on a treadmill or is given a pharmacological test. We're not going to go in detail here regarding those testings, but essentially we want to show you some of the schematics here. So during the stress, after the patient is rested, there are two sets of images that are taken. One is a stress image and second is a rest image. So the patient actually comes under the camera, and the gamma particles are recorded in a fashion such that it looks like a polar map. We call it a polar map, or almost like a bullseye, if you will, or the target, like the target sign. So the left anterior descending is mapped here, left circumflex is mapped here, and the RCA is mapped here. Why? Because the left anterior will supply the anterior part and the septal part. The RCA will supply the inferior mostly, and a little bit of septal, infraseptal, but mostly the inferior part. And left circ will supply the lateral part. So this is how the polar map looks like. So anterior, lateral, inferior, and septal. Got it? Okay, so now these are the three arteries, LAD, left circ, and RCA, and that's how they are traversing in the three-dimensional organ here. Remember that it's not just a two-dimensional organ, it has the depth also. So, and this is classically seen on these polar maps, or the target bullseye as we call it. So wherever the isotope goes, that shows the flow is going. So this yellow being the isotope, which could be the technetium-99, and most of the time it's either sestimib. We use a sestimib here, or sometimes we use the tetraphosphamine. But tetraphosphamine has been now for a long time, but sestimib is more acceptable. So these are technetium-99 isotopes. So just remember that if it's been ordered for you, as long as it's safe for you, you can go for the test. Now the concern here is between the stress and the rest, if the isotope is not changing its pattern, in other words, the flow remains the same, that is considered as normal study. Why? Because there was no difference between the flow between the stress images and the rest. So it is a normal study. So that's good. So you pass the test on that one, right? So the person comes in, gets on a treadmill, the isotope is injected at the peak of the exercise, imaging is performed, and the person waits for 2.5 hours. Now there's a gap between from stress to rest, depending upon the protocol, it's about 2.5 hours. And then you take the second set of pictures after re-injecting, and that's when it will show whether or not the technetium has changed in its flow. Now let's understand what's happening in a setting where there's a defect. Now the defect, say the defect is example. These are various examples I've done. So I have 3 examples here for you. The first example is showing left circ distribution where there is a defect during stress. That means the person actually during exercise did not show any flow going into the circ territory, in the left circumflex territory, which is somewhere here in this area. Okay, so that's your left circumflex. It's going all the way to the apex. Remember, the apex is at the center. This becomes the apex, and this becomes the base. So when you look at the heart, obviously this is your apex and this is your base. This is your apex here, and this is your base. And this is your apex here in this view, and this is your base. Again, it's a short video here we're doing, but we're trying to give you a great conceptualization as to how it works in a 3-dimensional area. Okay, so the apex of the heart is here, and this is your base. So in different views, this is how the heart will look like. But it's very interesting because nuclear cardiology is a full 2-year course. We're trying to give you small little snippets here between the videos, just so that you understand exactly how to make an interpretation of a reversible defect. Now we're talking about a reversible defect in a left circle lesion that reverses fully here. You see that the yellow or the orange came back within the circ distribution. Here it was dark. It came back here, so it's called a reversible defect. That means you had left circumflex ischemia only. So that's the good news, and this patient can go for PCI or can go for a PTCA. So if somebody is recommended a stent after the nuclear scan, it's because of this. You see a reversible defect. So whenever you see a reversible defect, that person can be revascularized, we call it, or can undergo a stent. Second example now. So that was the first example. Second example where you have a fixed defect. Now we are showing an example. Again, these are examples. So here I chose RCA, which is the right coronary artery distribution. So here there was a dark defect in the stress. Obviously, these are stress images, and the rest images are in this column. So in the rest, you will see the same defect persisting. So when it persists, it's called the fixed defect. And when it is called a fixed defect, the implication is that means there is a flow that did not even reverse during the resting time. So during stress, obviously this was present, and at rest also it was present, so it becomes the defect which is fixed, and therefore it's called infarct. And where is the infarct? It's in the inferior region. Why? Because we just looked at this is your inferior region that's corresponding to this artery RCA. Where is RCA? RCA in the artery is here. This is your RCA. That means the defect is somewhere here, and it's going all the way from apex to base. That means it is from the inferior defect is from apex to base, so the defect may be somewhere here in this region. Okay, so it gives you a better idea as to where the defect can be. So again, inferior infarct. So this is medical management only. You do not, and your boards, they might ask you a question: are you going to give a stent to this person? No, you're not going to give a stent. Why? Because it has a fixed defect only. So only medical therapy will be advised. Third example is where you have, say, let's pick up this artery, LAD, which is left anterior descending artery, as I've shown you here. That's the anterior descending artery. Now, this individual, when he or she exercises on the treadmill, there's a partial defect that is developing. In other words, it's not entirely fully blackened out, if you will. So there's an infarct ischemia, and then some of that will come back. You see the orange came back in this region as opposed to here. It was totally blanked out here, and here some of it is returning back. That means there is some viability here. So that speaks of myocardial viability. Now that's a very favorite subject of mine, for which I will do another video at some other point, but viability is very, very important here. A myocardial viability, implying that there is a portion of that viability, myocardium, that is viable. That means it tends to return back to normal, but not entirely. So there is an infarct and there is an ischemia. So it's an infarct plus ischemia here, you see. So it's a partial reversible defect in the LAD region. Where is the LAD? LAD is here. This is the one that is traversing the anterior part of the heart. So the LAD normally distributes the anterior part, which is your anterior part here, and goes all the way to the septum. So it goes to the septum here and anterior here in these two views. So there will be a darkening here, and of course a partial defect that will appear here. So in other words, partial reversible defects imply infarct and ischemia. This patient may or may not go for a stent. Okay, depending upon how much is the reversibility. If the reversibility is less than 5%, most patients would not go for a stent. If the reversibility is more than 10%, then they would go for a stent. Okay, so that's normally a cutoff between the nuclear cardiologists and the angiographers. Again, that's very personal, but then at the same time, individualized cases from one to the other may differ a little bit. Fixed defects, again, you have inferior defects here, and reversible defects, as I said, will imply that there is ischemia, and those patients definitely go for stent. And then if you have fixed defects, they are only managed medically. Okay, so in a nutshell, you've learned about what are reversible defects, what are fixed defects, and what are partial defects, and how the territories are involved, and how three-dimensionally they look like between these from grossly when you look at the heart from outside, and then of course in various little sections like the vertical long axis here, the short axis view here, and the horizontal long axis here. Here, this becomes the septum. This is your apical, and this is your lateral wall. Here, the apex is on the top. The anterior wall is on the top. Lateral is on this side here, because the right ventricle comes here. Remember, the right ventricle comes here. So this is your septal. So this becomes your septal, and this is your inferior wall. Same way here, you have a base. You have your apex, but this is your anterior wall, and this becomes your inferior wall right here at the bottom. So different sections, again, try to conceptualize this. And of course, remember, this is not a syllabus. This is it's a supplement to your syllabus, not a substitute, just as I always remind. All right. And of course, if you're having an emergency, please dial 911 and get to the hospital right away in the United States, or call for an emergency doctor, or get to the hospital and see a doctor right away. Okay, thank you again. This is purely an educational channel. We just want to make sure that the patients are well versed, and so are the doctors, obviously. So this way we can give you quick snippets before you go and attend your tutorial, before you go and see your clinic doctors, and of course before you go and make your bedside rounds. This way you are more knowledgeable when you actually go around and see your patients and talk to your attendings. So once again, thank you for being associated with MuniMeterHealth, your favorite channel, which is dedicated to medical education and patient education, both alike. Okay, thanks again, and we'll come back in another video on my next visit.